So what I wanted to talk about was enhancing how I'm trying to enhance patient confidence in my practice. I showed the other group this slide earlier today, but why do we care about patient confidence? We care about patient confidence because this is from you can't see it, but Watson and Benjamin's How's Your Health book. Because if a patient does or has poor self-confidence and is getting poor information, the likelihood of having a medical harm occur to them in the next year is about 20%. If they have good confidence and they get good information, the likelihood of them having a harm from the medical system in the next year is only 1%. So it's a 20-fold difference. The other thing that's interesting about this, if you look at it a little closer, is you'll see if they're getting really bad information. If I say, oh gosh, you scare me. Thank you, Michelle. If I say, like, hey, I hear smoking increases your heart rate, so that's got to be like aerobic activity, so keep smoking. But they're confident in the management of their disease, they still only have a 2% likelihood of having a medical error. But if I tell them everything great, if I am the best doctor in the world, but they're not confident in their disease, they have about a 6 to 8% chance of a medical error happening to them. So actually the patient's confidence in their own disease is a really good marker for how well you're going to do as a physician, but also how well they're going to do, which is more important. My patient's confidence level was only 48%. That's not terrible. That's about national average. But I wanted it to be better.
And it was 48% saying
48%. Yeah, I feel very confident in the management of my disease, whatever it might have been. Okay, I just happen to have a couple of nursing issues, so this makes it kind of a different thing for me. My regular nurse came down with myasthenia gravis, and so she's been kind of in and out, and so I needed somebody to help me out in the office anyway. Jenny Koninsky sang with me in the choir. She was a nurse who did cardiac rehab for many, many years, was outsourced because the cardiac rehab that she was working with wasn't profitable enough for the hospital. And so she decided that she was going to quit medicine or quit nursing altogether and do some sort of interior design thing. Anyway, I said, well, wait a minute. Maybe we can get together and do this. So let's see. So I asked her to come work with me. Her vision for the program was that she would meet with patients for 6 to 7 weeks, once a week, 30 to 60 minutes per session, usually about 60 minutes, and basically give patients numerous patient education handouts with increasing complexity to improve their knowledge base, and then develop an action plan, which again becomes increasingly complex, and then phone follow-up after that monthly. Okay. Then my vision was that the patients must be directly able to work on what they want to do. So the first question that needs to be asked when they show up is, what do you want to work on today? I didn't want it to be based solely on 1 or 2 major diseases. I didn't want it to be a diabetic educator. I don't want her to be a hypertensive educator. I want her to work on the problems that the patients are coming in with. And so these are the different categories of education that we had. Okay, stress management, dietary modification, exercise, starting an exercise program, and also information about the diseases if they need it. Mm-hmm.
Do patients select their problems then?
Yeah, the patients self-select if they want to see her and what they want to talk about.
How often if they're diabetic do they say, I want to work on diabetes?
Huh? Oh, I would send them as well. So if I was seeing a diabetic in my office, for instance, and their hemoglobin A1C has never been controlled, then I would say, hey, it looks to me like you might have some confidence problems in management of your disease. I would say it in English, though. And I would then say, I've got this great person that can help you with this and get you back to knowing exactly what you need to do for all the 1,000 questions that come up every day. And your diabetes will get under better control, and you'll do much better. So, and most of the people would say, oh, okay, let me do that. So she developed a patient education flow sheet for the different education processes that we have. She's old school RN, and so she's documenting like frickin' oh my God. And we didn't need that. And so I said, look, let's just get a checkbox. So you can just check which patient education handouts you gave, and you're not spending hours doing documentation when I'd rather you spend that time in direct consultation with the patient. So she basically will ask them what you want to work on, and then she'll pull those education handouts, and then we'll go from there. She's using a lot of stuff from PCNA, different groups and websites and things like that. So all the patient education handouts that she's giving are free, essentially. Yeah.
Okay. Diseases that people needed the most information on, and where did she get her patient handouts from?
She got them from, a lot. You can see from up here, from some diabetic associations, from PCNA, which is the Coronary Nursing Association. I don't know. So I don't know what it stands for. But so she can get, and then you can go to a lot of government agencies actually have, they'll send you 50 handouts on this, that, or the other. And so she's been able to get all those. And what she does is she'll figure out which handouts the patient needs. She'll check them off. She'll give them the handout.
So what are the top 5 diseases that people needed information?
Well, good question. So what are the top things we were looking at? Well, she schedules the patient, and okay, this is the process of how it works. So that's boring. Okay. So okay, this is the results on the number of patients we've had. So we've had 83 people start the process, and more than 28 of them have completed more than 5 visits, and only 14 have only had 1 visit. Reasons for dropping out usually are due to life situations. At least that's what they tell me. It could certainly be personality issues with the nurse. It's hard to say. But most people, what we find is that most people who are dysfunctional, and remember these are the most complex patients I've got, who are dysfunctional in some area of their lives are going to have a hard time coming in once a week to see the nurse, and they're going to get lost for follow-up. So. The age range is 21 to 90 years old, with 55 female and 28 male.
How many do you think you offered that service to get 83 patients, roughly?
Probably 100. I mean, I've offered it to all of my patients, but I really try and sell it. We don't have any copays associated with it, and so I really set the bar pretty low, so they don't have many hurdles that they have to overcome. No,
You're just having them come in.
Right. Yeah, I'm doing this as a service to my patients. I'm paying her. I will charge Medicare if they're over age 65 for a nurse visit, and that helps. But I'm paying her basically out of the pool of money that I have. It's a financial loser at this point. I get that. Yes.
Why did you decide to do that?
Why did I decide to do that? Because I felt that improving my patient confidence was the most important thing.
But couldn't you do that and get paid for it?
I felt like if I charged money to my patients, the adoption would not be very high because they wouldn't want to pay a copay every week. Yeah, and I have gotten I've gotten meaningful use funds that I figured I would use the meaningful use funds to do something like this. So these are the goals. The big ones. Weight management is the one that people really wanted. Weight management and starting an exercise program, eating healthier, getting diabetes, hypertension under control, stress management, and then some others. Like we had one lady who she was has chronic renal insufficiency, was told by the nephrologist she needed to be on a renal diet. She then had diarrhea and was told by the gastroenterologist she needed to be on another diet. And so she just stopped eating and was losing a ton of weight. And so she needed to meet with somebody to say, look, let's go through a diet plan so that you can eat something. So obviously most people had more than one goal. So this is the average weight of the people entering into the program. They're 221 pounds, essentially. And the average hemoglobin A1C for the 11 diabetics that I sent to her was 9. Again, remembering that is not my average for the population, but these are the most complex patients that I've had that have never been able to be controlled. So we're still having the process ongoing, but so far the average weight is down to about 208, which is a 12.8 pound reduction. And we've had some guy, he's now up to 75 pounds of weight loss since last October. So it's been pretty successful in terms of getting that under control. And hemoglobin A1Cs have also dropped to about 7.7 in the population. What we're finding is also it's sustained the drop in hemoglobin A1C and the weight loss has been sustained over a year for people who we've had a year follow-up.
Six or seven?
Six visits usually. There's been some that have had 8 visits, but 6 is the maximum.
Even still, you're saying a guy from like last October. It's not like he's still seeing this person.
No. So the idea is he's learned what he needs to learn, and he's now implementing it. The reason why she wanted to go 6-7 weeks, actually she wanted to go about 10-12 weeks, and I told her no. But the reason why she wanted to do 6-7 weeks is because it's like she's coming from the cardiac rehab background where it takes a while for it to become habit. And so she's trying to implement this and make it a habit for them and help them. The reason why she has the hour-long sessions each week is because she's really trying to answer those 1,000 questions that come up.
John, did you get a chance to measure that? Maybe it was like going to next measure your patient confidence?
We're starting to do that. We didn't do that initially. What we're finding is that the patient confidence is going up. But that's for my next year is what I'm looking at as patient confidence levels. And there's no question that people who have done it people who have gone through the program their level of confidence is really, really good. So, okay, so let's see. More sessions the patient attends, the more likely they would have success. If they just come to one and they leave, they actually don't. It doesn't usually make that much of a difference. Results for weight loss and hemoglobin A1C is sustained, and then having the nurse in-house. I think it's helpful. I think because it adds to the whole patient-centered medical home thing where this is the one place to go. It doesn't have to be. It doesn't have to be in-house, but I think that it's helpful. She also can alert me. If she's seeing a patient who she's worried about, she can say, "Hey, you need to call them, or you need to, take a look at them." So it is helpful. Limitation, of course, data collection is still ongoing, and the hemoglobin A1C drops has been quite 3 months, so we haven't had a lot of follow-up on patients yet. And obviously, these are the most difficult patients that I have. Further study is measuring self-confidence. That's what we're going to start doing now. All new patients are getting a simple question. How confident are you in managing whatever you're coming in for? That was worded better than that. And then the second question is, what have you tried in the past to succeed, and how successful have you been? Our follow-up questions to that. And we're having them do it initially, and then at 1, 3, 6, and 12 months. We'll have them do that questionnaire, and hopefully we'll get some good data to see if the patient confidence level is going up and what happens there. And then I do want to start redoing How's Your Health to see if that affects my overall practice confidence score. I think it will, because again, these are the most.
So you just pulling out self-confidence questions from How's Your Health when you say measure self-confidence prior to and then again, or
we made our own questionnaire based off of one of the questions from How's Your Health, but basically on my own questionnaire on what I was specifically interested in. So, yeah.
Are you doing any phone follow-up, like when they finish the in-person?
Yeah, she's doing that. Jenny will call. She makes a list of people that have been out for 1 or 2 months, and she'll call them when she has a moment in between patients. Yeah.
And one other billing question: did you talk to these people if they would have participated if they had a copay?
Yeah, and the answer is that a lot of them would. A lot of them would have paid. As a matter of fact, most of them are stunned that there isn't any fee associated with it. But given that a lot of these patients have difficulties in multiple aspects of their lives, I felt like if we added any barriers to coming in, that the likelihood of adoption would be much, much lower, and I was interested in seeing how this worked. Yeah. Other questions? Cool. Let me turn it over to PJ then. He's got the next one.